Okay, sorry for the delay. I'm about 3 hours late, 3 hours and 21 minutes late. But I needed to take care of a few other things before we got started here. I have chosen the desert behind us because our topic is anything but boring. So you have something to kind of engage with here while you listen to the exciting world of personality disorders. So without further ado, I will share my screen and we will go with, where are these at? I don't know why this is working. Okay, we'll go with this one here and share. Okay, I'm screen sharing now. Good. Okay, and this is what we covered in class just the other day. So I'm going to move myself someplace less conspicuous here. Oh, I'll be down here. All right, so personality disorders. Personality disorders, you got to remember personality is something that you're really not aware of. It is ingrained, it's impacted by our family, our traditions, societal norms, coping or maladaptive coping, lots and lots and lots of ways that our personality is developed. Oh boy, sorry. Lots of ways. So it has a lot to do with how other people see us. Now, if it's a disorder, that means usually that they're inflexible, they're hard to change, very maladaptive. The problem with that is they don't think there's anything wrong with them. And if there's nothing wrong with them, then why do they need to have therapy? And why do they need to take pills? And why do they need to do anything to change who they are? They like who they are. So they won't. So they're really, really treatment resistant with a personality disorder. Also, with personality disorders, they usually have what's called an axis one or a primary psychopathy, like depression or bipolar or schizophrenia. And the personality disorder developed because of the coping or the maladaptive coping that they used with this mental illness, trying to get through this mental illness. So okay, some of the personality traits, and these encompass all of the personality disorders. They are variable amongst them. So negative behavior towards others, mainly antisocial. Anger and or hostility, you will see that a lot with your cluster Bs, all your cluster Bs. Irritable, labile mood, that is going to be your borderlines. Lack of guilt, remorse, cold and uncaring, that's your antisocial again. Impulsive or judgment, your borderline. Irresponsible, not taking account for your own actions. Sometimes you see that in histrionics. And then risk taking or thrill seeking, you see that a lot in narcissism because they really just think that they are it. They're the center of attention. They are God. They exploit other people. Narcissists do. Personality disorders, 10 to 20% of the population. I think it's much higher than that, depending on the psychopathy that they have and how soon they get treatment after diagnosis. So it tends to be a little bit higher in the lower socioeconomic classes because the amount of resources that those people have are not as broad as those that people in higher socioeconomic classes would have. Arnold Palmer there. Good stuff. We already talked about being treatment resistant. Theories, lots of theories why we get personality disorders. People just born with that kind of temperament. Psychodynamically, some people are self-directed, some people are cooperative, some people believe in transcendence, self-transcendence. Those are all theories. Like if you don't believe you're an integral part of the universe, you might go off and isolate yourself or withdraw from society. That's a schizoid or a schizotypical. They do that. Um, if you are not self-directed, if you have to stop and ask permission and things, it's more of a dependent personality type. So again, these etiologies are across all forms of personality disorder. Culturally, we have to take into consideration how different cultures look at personalities and how they are developed. Some cultures see women as secondhand citizens through our perception. But if you were to talk to those females, they will tell you that they are well taken care of, that they are the primary person in their spouse's life, and they are put up on a pedestal. They're not in any way, shape, or form secondary citizens. They are the main part of the household, and that's just who they are, and that is that culture. You see that through American eyes, that's not necessarily what we would view as being culturally appropriate. So some different views about avoidant and dependent behaviors, that kind of is like where we look at one of those females and say, hey, they're made to wear the burqa, they're made to only wear skirts, they're made to only, dress this way or act this way or behave this way. And I really don't appreciate that. I don't think that that is being, what you can be, fulfilling everything. But remember, those things are perceptions, and everybody's perception is different, even within the same culture. And you just have to be accepting and be genuine and have unconditional positive regard for everyone that you meet. Okay. Okay, so we already talked about this in class. They are treatment resistant because they don't think there's anything wrong with them. And now we get into the clusters. Okay. Cluster A's, cluster C's, like I said, they don't scare me. They're just, cluster A's are just odd. There's just Muhammad on the mountain, You get the paranoid ones, the schizoid, schizotypical. Schizoid, schizotypical, it kind of leans towards you thinking they might be schizophrenic, but they're not. Schizophrenic is a primary diagnosis. That's a psychopathy. Being schizoid is schizotypical is a personality. So they may act odd or unique. And that might be something that you would see in the behaviors of a schizophrenic, but it doesn't mean that they are schizophrenic. Okay, so like they are isolative or withdrawing from society. Schizophrenics do that, but it doesn't mean that your schizoid personality or schizotypical has schizophrenia. Okay, so just understand that. Not that they could, but chances are they don't. The paranoid, they don't trust anybody. They use a lot of projection. So they say, I don't trust anybody because they're all out to get me. That's projection in a nutshell. They have a lot of fights with people in authority because the people in authority are out to destroy them. So for the nursing interventions are going to be very formal with them, business-like. You want to involve them in their care, allowing them to have a voice, and then encourage them to look at situations realistically before they decide to do something. Like they may say, hey, before the guy in room 2 barges into my room and hits me, I'm going to go hit him. So you need to encourage them to look at things realistically so that they are not reactive, but rather proactive. Schizoid, socially detached, restricted emotions, and very intellectual. This is like Dr. Frankenstein up on the mountain. He's withdrawn from society. We have to teach these types of personalities to engage with society and how to act appropriately with society. And schizotypical, pretty much the same thing. They have a lot of interpersonal deficits, though, behavioral idiosyncrasies. They just really don't pick up on social cues very well. When I think of the schizotypical personality, I don't know if you guys watch Big Bang Theory, I think Sheldon. So between schizoid and schizotypical, he probably meets them both, but this is probably who he was trying to emulate. We have to teach them self-care. We have to teach them social skills, how to engage with other people, what other people may be feeling and thinking, and teach them how to function in a community or a society. It's very difficult. They're not scary people. They are just odd, just a little bit odd. And because of that, they have been given a personality disorder. Cluster Cs, these guys are the anxious or scared ones. This is where you see like a lot of OCD behaviors. So obsessive behaviors, avoidant behaviors, and dependent behaviors. And the cluster Cs are not dangerous people. They're not scary people. They're just really anxious and scared for themselves. They're fearful for themselves. So the obsessive person, they're the perfectionist. They really think that something bad is going to happen if they don't follow sometimes a ritual. Orderliness is a priority for them. They have trouble with decision making. And they really, really think negatively about themselves. So, oh, I'm a horrible, terrible person. I really need to do this right. So we try and do the cognitive behavioral therapies with them and restructure, decastrophize. What's the worst thing that's going to happen if you don't go in and check your, curling iron 4 times? What's the worst thing that's going to happen? Let's think about this, and they'll say, oh, burning down my house. Well, that's not very realistic. So you really just got to work with them and looking at those different points of view. Take a few risks. Avoidant, these are the people that everybody probably thinks is antisocial, but because they avoid society, they avoid people. They're very uncomfortable, hypersensitive to negative evaluation. They just sooner not be all in. They would sooner just not go to parties, that kind of thing. So for them, we do a lot of help them do a lot of positive self-talk. There's little, I was talking about in class where they could do the little post-it notes, you are enough, or, you're wonderful, or have a great day, or something like that, and stick them on their mirror where they can see them and engage with them. We help them reframe what they're thinking about. I mean, if you do go to the dance, what's the worst thing that's going to happen? You're going to be alone at the end of the night. Well, that's not so bad, really, if you think about it. And then a lot of social skill training, we work with the people. Dependent, this is the one I struggle taking care of. These people are just so submissive and they're so clingy. And, I told you about my friend, how she had to ask her husband before she did anything. Couldn't go out to dinner or lunch or hang out or, go for a drive in a car, nothing. She had to ask permission from her husband that would be okay. So we teach them a lot of assertiveness and how to express their feelings. We teach them a lot about how to be, self-reliant, because a lot of times they just basically cannot function. They don't think that they can function without their spouse. So sometimes you see this in the elderly. It's just kind of occurred to me. The woman who has always taken care of the checkbook and has always gotten the groceries and has always taken care of her husband, made his appointments and things like that. And now she's dead. And then the husband comes along and he doesn't know how to write a check and he doesn't know where to find things in the grocery store that he likes. So he would have been more of a dependent personality on her because she was the assertive one. So it just, again, it's really only a disorder if it impacts your life in a negative way. So related personalities, depressive personality disorders. We'll talk about this. Depressive personality disorders, dysthymia. Dysthymia is just kind of like Eeyore off Winnie the Pooh. The world is just a horrible place all the time. And some people are born that way, and glass half empty, very negative. They're not really depressed, but they have a depressed mood, and there's a difference. And then the passive aggressive person, they just really they're not assertive, and you got to do a lot of assertiveness training with the passive aggressive people. Okay, pessimistic, listless, saying blah blah blah. We want to keep them safe. And then the passive aggressive, negative attitudes, passive resistance to demands for adequate social and occupational performance. Yes, okay, I'll do that. And you don't have to pay me, but oh my God, can you believe? Then they turn around and stab you in the back. They tend to blame people. So we really work on assertiveness training with them, saying what they mean, meaning what they say, and how to express how they're feeling overall. These guys are the scary ones, and we kind of already talked a little bit about them, the borderlines, the antisocials, and the narcissists, and the histrionics. The cluster B traits are dangerous. Now, I know that we watched the Iceman tapes. We watched a snippet, the Iceman tapes. There's many, many more. If you have an interest in that, just YouTube it. Again, for the cluster Bs, we're going to treat their symptoms with different mood regulators, treatment for aggression, anxiety as needed, and perceptual disorders like hallucinations and things like that. Individual therapies do not work really well. I'm sorry, group therapies do not really work really well in the beginning with these guys. You want to do individual therapies and then get them towards group therapies. Dialectal therapy works best for your borderlines, and you'll see when I show you the borderline video here how the nurse used talking to kind of move that borderline a little bit further than she wanted to go in a positive way. Okay. The antisocial personality disorders, again, there's a lot of theories out there. The big one for this personality disorder in particular is that they never attained the trust from the trust versus mistrust developmental crisis. So that's a theory. I tend to believe it. I don't know, but it's out there. They are very deceitful, very manipulative. These are your serial killer types. Really no emotion at all. They really have none. Narrow view of the world, no insight, poor judgment, egocentric, but they really have a low self-esteem. They serve their own needs. They really don't care about anybody else or anything. These are the ones that start fires and bedwet, and that's the trifecta. Damage to personal pets and personal items. So they burn maybe a barn down because, they just felt like doing it. So they did it. Your dog goes missing. You never see him again. Well, probably the kid with antisocial at the end of the block is taking him and did something to him. So the antisocials develop from child psych, if you recall from your independent review. The antisocials are considered on the continuum of ODD, conduct, and then when they're adults, they're antisocials. Just kind of think of it as a continuum. So that's where a lot of theorists think that it comes from there. But I think, I guess I don't really understand how someone with ODD can ultimately become antisocial if you intervene. So I guess if you don't intervene, they can. Antisocial, we want to look at their therapeutic relationships, limit their behaviors. Well, the boundaries are big. Teach them that they need to, go take a time out. Encourage them to flesh out their roles. If they want to be somebody's wife, then to pursue that, or they want to be somebody's husband, pursue that role and understand it. Now, the thing with these guys is that they have to want to change, and they may not really change, but they learn behaviors that are considered acceptable. So they learn what they're supposed to do, and they actually do it if they want to change. But if they don't want to change, they don't think there's anything wrong with them because they're a personality disorder. That's probably what's going to happen. They won't. And they're, like I said, they're scary guys. You saw our Iceman. They do manipulate. Borderlines, very unpredictable, very labile. They split. And again, I told you that if they're splitting something, it means maybe they're splitting staff, and it means that they're all good or they're all bad. So if they're polarized in their thinking, it's one way or the other. There's no gray area. That's the splitting. Threats to self-harm. A lot of times your borderlines actually will cut, and it's for stress relief or for attention. They don't consider themselves to be suicidal. We assign that language to them. Sometimes if you see someone cutting, before you understand that it's really a personality type. They do socially isolate. Lots of times for borderlines, they do these behaviors, they act the way they have because they've had some sort of childhood trauma. And this is their maladapting coping. That's, another theory that's out there. We want to do safety, no harm contracts with them. So we get them to sign a contract so that they won't cut or they won't harm themselves in any way. And lots of people say, well, it's just a piece of paper. It's not going to do anything. Well, that's true. But the thing with borderlines is, or the thing with contracts is, when you sign something, it makes it real and you are more obliged to follow through with compliance. So that contract really, it just kind of like works on their mind. Work on the limit setting, work on boundaries with the relationship. I mean, they may say, hey, you're my best friend, and nobody else here loves me or likes me, blah blah blah. You just need to remind them we have a professional relationship. This is not a friendship. And just keep strict on those boundaries with our borderlines. Work with communication skills with them, emotional control, cognitive restructuring, positive self-talk helps. And then structured daily activities really help your borderlines. If every morning you wake up at 7 and you have a shower and then you have breakfast and then you start your car to warm it up and then you get in your car and you go to school by 7:30 or 7:40, and you do that every day, that helps you control the behaviors that you are going to exhibit because you just don't have time for them. And then the nurse, of course, would look at how they are behaving and how they're reacting to the involvement. And then let's go ahead and let's watch this borderline. I promised you guys this. I'll bring this back up again. Where'd I go? That's not good. Shrink that back down and go here. And we are going to stop the share of this one. Hi. And share, and we're going to watch this video. Okay. So I want you to see this borderline. And remember, if you have children in the room, you'll want to get the children out of the room because this is, there's a lot of very strong language. Okay. With this, a lot of strong language. Okay, so first we'll watch what you should not do with the borderline, and then it'll go into what you should do, the proficient nurse. Okay, are we ready?
Hi, my name's Sue. I'll be doing your admission with you this evening. Thanks for waiting. Now, did you get something to eat? I'm not hungry. Where's my doctor? Well, she should be here within the next hour. Now, can I ask you a few questions? It better not be Harris. Pardon? Harris. My doctor, it better not be Harris. I want McLean. McLean was my doctor last time. I don't want no goddamn Harris coming near me. I don't actually know who your doctor's going to be. We just put the call in. Well, I'm not asking who my doctor is. I'm telling you. I want McLean as my doctor. Now get on the phone. Christy, I can see how this whole thing is upsetting to you. Your admitting physician put a call into the doctor on this unit, and I'm sure when they come, you can talk about your preferences and they'll... Yeah, right. What a load of crap. Okay, well, can I ask you a few questions then? Like I have a choice. But you want to diagnose me? Like I'll save you the trouble. They called me manic depressive, major depression, schizoid, borderline personality, which is my personal favorite. What the fuck does that mean? Borderline personality? Look, did you get it all? Are you done? I don't really want to try and diagnose you. It's I want to find out how you're doing overall. Overall, I'd say overall, not so good. Like last night, I was bleeding from my wrist like a pig because I cannot cope with the fact that they want to come and take my son away from me again. And before that, I'm dealing with AISH and social services because I can't afford to pay my rent for 2 months and they're going to take my apartment away. And living on the street is really going to help me keep my son. And then I get this call from my best friend who's in the hospital who may never walk again. So, overall, oh, did I tell you that they're going to come take my son away from me? I'm, uh, I'm really sorry. Like, it sounds like a lot. How the fuck would you know? You with your little nursey job and your little nursey life? This is fucking bullshit. I don't want any more questions. Where is my fucking doctor? Look, just fill out the form. Just write exactly what they wrote the last time. It's always the same. I've been in here enough times. You can just write what they wrote the last time. And get on the phone and get McLean. Um, Christy, as I mentioned before, you can talk about that whenever it is who comes to see you is here. They should be here shortly. Now, I just ask a few more quick questions and then I'll let you rest. I told you, no! Write down exactly what they wrote down the last time I was here. It's just the same shit. It's just a different day. We can't really do that. We need emission data each new time you come in. Data? Is that what I am? Just write down that I'm suicidal, I'm uncooperative. What else do they call me? They call me inappropriate. I'm inappropriate. Just write down that shit and leave me alone. And where is my goddamn doctor? Um, so you mentioned that you were suicidal. Yeah, I'd say cutting my wrist so I'm bleeding like a pig is pretty fucking suicidal. Yeah? So what about right now? Like I'm gonna tell you. I tell you, and then you tell my doctor who's gonna come in, and then they put me in here for a month, and then I have no fucking chance of getting my son back. It's like a game. You guys are all so sick. Um, so how about your mood then? Fuck. What a stupid question. What about my mood? What do you think my mood is? Oh, it's great. Oh, I just can't help remembering that I was sexually abused for half my life. And I have no idea where my son's father could possibly be. But things are just ducky. I'm great. Do you have any other stupid questions you want to ask me? What the fuck is wrong with you people? No, that's it. I'm done. I'll come back later. Don't bother. Just get my doctor. Well, I'll let you know when she gets here. Is there anything else? Shut the door. Hey there, Christy. My name's Sue. Hi, Sylvain. Into jail? Yeah, I'm getting pretty cozy in my little prison cell here. How come no one's been here to see me? Where's my doctor? Well, it can seem like forever before someone comes in, but your doctor's been called and will hopefully be here soon. Now, in the meantime, I have a few questions that I need to ask you, and it might help pass the time. Oh, it better not be Harris. There's no goddamn way I'm even talking to Harris. I want McLean. I want McLean as my doctor, as my doctor last time. I want you to get on the phone and get McLean in here. I honestly don't know which doctor's going to come see you first this evening. Now, if you have a preference in physicians, or if you have a regular physician that you see, you can let that be known at the time whenever he comes. There is no way I'm going to see Harris. I'm not even going to talk to Harris. Christy, I don't know who it's going to be right now. And I actually don't want to waste either our time or energy talking about who it might or might not be. Now, I have some questions I need to ask, so the sooner we get started, the sooner we can be finished. Well, it might be a waste of time for you to talk about what doctor I get, but sure the hell isn't a waste of my time. You know, I'm just not, I don't know if you heard me, I don't know if you're listening, but there's just no way I want that jerk Harris as my doctor. I want McLean, I want you to make a phone call and get McLean down here. It's my legal right to get a phone call, and I want to get on the phone and talk to McLean, or else you're going to get sued. Christy, I believe you've been through admissions enough times to know that unfortunately that's not the way that things work here. Now, I hear you loud and clear. You want McLean and not Harris. I will pass that information on to your meeting physician. However, it's ultimately up to you to make your wishes be known to the physician at that time. Now, that's all I'm going to talk to you about physicians, because that's honestly the best that I can do for you. I do have some questions I need to ask to make sure you get the best care while you're here. So, Christy, what was going on for you that led up to this admission? I told them everything in the emergency department. Don't you guys talk? Have you ever heard of a telephone? I know it seems like we might not talk to each other. And I can see why you're worn out and frustrated by this whole process. But since I'm the one that's providing care for you and the one that's going to plan your care while you're here, I want to hear it from your own lips rather than someone else's. So, what's been going on? Looking at your wrists, you've either been cutting to reduce stress, or you've been trying to end it all by committing suicide. What's up? Well, last night I just thought, what is the fucking point? You know, I cannot cope with them trying to take my son away. And then those idiots in the government holding back my AH payments, and it's like I'm gonna end up on the street. And then there's no fucking way I'm gonna have my son. And then I got this phone call from my friend from the hospital, and my best friend's been in a motorcycle accident, and she's probably never gonna walk again. And then I keep having these flashbacks, fucking flashbacks to my abuse. It's like, fuck, how much am I supposed to take? You know, how much can a person take? And it's like, I don't even fucking care anymore, and I can't imagine why you would care. I can't imagine why anyone would give a shit. Well, believe it or not, I do care. As long as you're my patient today, I care very much what goes on with you. That's just the fucking point. It's just like, the second your fucking shift ends, you forget all about me, and it's just like, back to your own fucking great little life. Christy, with all due respect, this isn't about me. For right now, in this moment, I do care about you, and you have my complete and full attention. So, how are those thoughts coming? Those thoughts of just wanting to get it over. Do you think I'm fucking stupid? Do you think I don't fucking understand this stupid little game? If I tell you I'm feeling suicidal, you're gonna go tell whatever doctor they send. And he's gonna come in here and he's gonna fill out a form, and I'm gonna be here for another month or more. You know, I know the Mental Health Act.
I know how it all works, and there is no way I'm gonna get my son back like that. Fuck, there is no fucking way I'm gonna play your stupid little game.
Look, I can see why this seems like a game to you. And I can certainly appreciate the fact that this might affect you seeing your son. It's perfectly understandable. That being said, Christy, this isn't a game. This is about keeping you safe and keeping you alive so you can see your son again. Now, if you really do want to see your son, you have to work with us. I mean, really work with us to make sure that you don't try killing yourself again. And part of that work is letting us know how your suicidal urges are going.
Mm-mm. This is sick. This is a trick. You're trying to trick me into telling you something, and then you'll tell the doctor and he'll fill out a form too, and I'm going to be in here for 30 more days.
Okay, Christy, well, what do you think? How are we going to solve this problem? Where we try and balance your fear of us using whatever you say to keep you in here longer with the need to keep you alive through this crisis so you can see your son again. How do you propose we solve that problem?
I don't know. I just don't know who to trust.
I know I can appreciate how hard it must be to trust any of us. But if you want to get out of here, get better, and see your son again, your very best chance is to work with us. Christy, I can see by the difficulty you're having answering my questions that you probably still are having some suicidal thoughts. And that's perfectly understandable given that your attempt was just last night. Am I right? Okay, well, let's just assume that most people in your situation would be pretty suicidal. Okay, and for the time being, let's just forget about all that mental health act. We can deal with that later. We have to focus on the most important things, which is obviously your depressed mood and your suicidal thoughts. Now, given that your number one object here is to get out of here and see your son, what do we need to do about the business of your suicidal thoughts to keep you safe?
I don't know what the fuck you're talking
Well, some people don't just have suicidal thoughts, they actually have a plan on how they'd commit suicide. Now, for you yesterday, that was trying to slit your wrists. What about today? Do you have a plan or a way of trying to commit suicide while you're here on the unit?
about. I don't know. Like I tell you.
Well, is there anything you might do to commit suicide? Anything hiding that we didn't find?
Duh, like I would tell you if I did, you just take it away.
Christine, it seems like you're the one who's playing games now. Look, I'm here to help you stay alive and see your son. That's what you said you wanted. Now, in order to do that, I need to know if you are having any plans of trying to commit suicide on the unit in the next few days.
No.
Honestly?
Yes. I mean, I'm not gonna try.
But if you did have a way, let's say someone gave you razor blades or something like that, would you tell us or would you try to commit suicide?
These are fucking stupid questions. How the hell am I supposed to know what I do if I don't even have anything?
Okay, well, we'll just say you're not sure. We'll leave it at the fact that you don't currently have the means to try to attempt suicide, but you may be a danger if you do find the means. So then, how's your mood? What are you feeling like?
I fucking hate that question. What good is it to ask me that 10 times a day?
Well, I'll put it another way then. How's your mood on a scale of 0 to 10? 0 being pretty much rock bottom, such as during your suicide attempt, and 10 being your normal self, feeling great.
I've never felt great.
Fine. 10 being the best you've ever felt then. So how's your mood right now from 0 to 10?
Well, seeing that I'm in this place and I have no idea what's happening with my son or my finances or my friend in the hospital, I'd say it's like a 1. You happy? Now you know how low my mood is. You can keep me here for another month.
Okay, well, that's still pretty low. Overall, is there any time of the day that you might feel a bit better?
Ah, fuck. Can we just stop this? Ah, no, God, just enough with these questions.
Well, what kind of questions would you find helpful?
I don't know. I want to be left alone. I want to know where my doctor is.
I can appreciate the fact that you want to be left alone. I know we can finish most of that later. But I do have one more question that I want to get started on.
What?
Well, it's just that while you're here, I want you to feel like you're working on some of the issues that have been causing you stress. Now, you mentioned a few things like your son, your finances, your friend's accident, sometimes of when you were having sexual abuse. Now, that's a lot to deal with, obviously, and it's pretty unrealistic to think that you can deal with all of that at the same time. So then, while you're here, what do you think the biggest thing that you need to deal with is right now before anything else?
Well, I guess I need to find out if I still have a place or if I've been kicked out of my apartment. To see if whether have a place to live or if I'm on the street. I need to talk to my landlord.
Okay, so the housing thing is a pretty big priority. What do you think the biggest thing is that we could help you with that?
Well, I mean, I need to go and need to speak to my landlord and see if he said something about if not paid by today, then I'd be out on the street. So what I need is for you to let me go. And I need to go and I need to go and I need to see my landlord. I need to get out of here.
Christy, due to your suicide attempt and you're still high risk at suicide, I don't think it's realistic for you to leave the hospital right now. However, can I make a suggestion about your apartment?
What?
Well, I'm going to call Dave, our social worker, and I'm going to explain your whole situation to him and see if he can come up and see you. Now, there might be something he can do if you just give him a bit more information on your finances and your landlord. Would you be willing to talk to him?
Yeah, whatever. Fine.
Well, has anything else helped other than this?
No.
Okay, well, it looks like Dave's your best bet then. Now, you have to be willing to work with him. Now, are you going to be willing to work with him? Christy, it's up to you. It's your decision if you want to get help or not.
Yeah, fine. Whatever.
Okay, well, I'll take that as a yes. I'm going to call him and let you know what's happening as soon as I know. I heard you say something about wanting to be left alone, so I'm going to go and check on my other patients, but I will be back to ask you a few more questions later.
Fine. Where's the phone? I'm sick of waiting here. I want to talk to somebody about getting out of here.
There's a phone for the patients out on the wall by the shuffleboard table. Just please keep your call to 15 minutes or less.
I'll talk as long as I need.
Well, if after 15 minutes you're still on the phone and a patient needs to use it, you might be asked to get off. We all have to extend the same courtesy to each other. Well, I'll talk to you later, Chrissy.
Oh, that was fun. But that's borderline, very labile, very emotional, very high maintenance. But that is what they look like. So back to where we're at. Here we go. Alright. We already talked about the narcissistic. He is the center of attention, not desirous to be, but he is. The histrionic, very emotional, attention seeking, but they're not very sincere about things. They have to be the center of attention. They really have to. We like to work with them on their social skills, maybe some role playing on what's appropriate behaviors, help them understand what their strengths and weaknesses are. For the elderly, if they had a personality disorder going into age, then yeah, it's going to persist. But if they didn't, and all of a sudden they start acting out in particular ways, you have to really look at how they're dealing with or coping with the changes that come with age. Has their spouse died? How has their friends died? Are they engaged with society at all? Are they avoiding it? Are they staying at home? So we need to look at that things, because if they're maladaptively coping, and that can lead to addictions in the elderly. The desired effect for the elderly is that we get them to that point where they say, hey, my life was worth it. That's what Maslow says, or not Maslow, but Erickson says we have to get them through to have a dignified end. And if they're aging badly, that's almost a cry for help, that we need to help them with that. We do want to help health promotion for all your behavioral health problems, especially personality disorders. We have to help focus on mood stabilization, decreasing that impulsivity, and developing those social and relationship skills. So we give nursing interventions for self-care, sexuality expression, sometimes budgeting. It just increasing that self-worth and well-being helps them to improve their health. And then you need to take care of yourself too. Need to be very clear. Like that nurse in the last interaction, I thought that she is the best example of a clear person. You got to keep the boundaries there, the limits there with personality disorders, and deal with your own frustration, because people are not going to change overnight, especially for personality disorders. And remember, because we don't want to be divided, we want to work as a team. We got to have frequent meetings with our coworkers, and come together as a united front. Okay. And I guess that is everything with personality disorders. If you want to go back and review the Iceman tapes, you can. There's a nice documentary on Ted Bundy for narcissistic personality, and then schizoid. I can't think of one right off the top of my head. As far as something on YouTube, excuse me, something on YouTube. So just kind of know that they're the odd ones who, socially isolate. The quiz is going to be ready to go. It's already ready to go. We'll come in on class on Monday, take the quiz. I know what I wanted to show you guys. Do a screen share. No, don't want to see that one. Gosh, probably don't even have it up. Okay, hang on. I was going to show you, shrink myself down. Oh, okay, can't shrink it down. Can I do that? Yeah. All right, so I wanted to show you. Wanted to show you how things were going. All right, so back to Zoom. Zoom and increase this again, and we're going to screen share again with our course modules here. Okay, so we're going to share that. All right, so I told you I kind of moved things around a little bit, so I wanted to go through this with you. You're way down here. We did addiction. We just talked personality disorders. This is the one I promised to upload for you that actually has the cluster identification in it. Next week, we're going to do the quiz over personality disorders. We're going to talk about depression. We're going to talk about suicide. suicidality. Then the week following that, the quiz over depression. We're going to talk about bipolar. You're not required to do this, but it's an escape room and it's regarding bipolar. So it's kind of something fun to reinforce the content. If you want to do it, do it. If you don't even worry about it. So, but it's there just for fun. Then we have our quiz on November 4th. We have our quiz over bipolar. We're going to talk Alzheimer's and dementia, delirium kind of issues. But on November 11th, there's no class because it is Veterans Day, I believe. You're going to take your quiz over the cognitive disorders at home. Okay. So just kind of, we're going to get the lecture here, and the following week, you're going to take it at home. And then November 18th, we're going to talk about schizophrenia. We're going to talk about gender, which is your sexuality. And we have a little case study we'll do in class together. Hopefully this will be impactful because the very next week is our HPS day. And we do have a quiz over schizophrenia that is going to happen. I'll show you here. Yeah. Here's our HPS day schedule. Ooh, I forgot changes. It's going to be actually 8 to 12 now, not 7 to 12, because a lot of the places don't open till 8. So I have to change that. Going to be 8 to 12. I've put you in your groups already, so you're welcome to take a look at that and see which group you're on. And then you're going to follow the group schedule. This is going to be 8 to 9, 9:15 to 10, 10:15 to 11, and 11:15 to 12. Okay. So I have to change these times. Wherever you land at 8 a.m. is where you're going to go. Okay. So say group A, 8 a.m. Group A is going to be in the nursing lab. That's all these guys, Lexi and Aiden and Violet, Kelsey Peyton, Chloe, Blair, Mia Rosa, and Bennett. You guys will all be here with me in the nursing lab. The lab part is the far part, not the one where you practice in, but the other one with the seats and the chairs. So you're going to come down there. Group B, this is going to be Brian and Tamron and Gabby and Floor and et cetera, et cetera. You guys, group B, are going to, at 8 o'clock, are going to be at Coleman. Now, I don't know if you guys need addresses or not, but I will put some addresses. I'll put some addresses on your module for you. Group C, again, this is Kama and can't remember what the name is. Kiera, Jameson, these guys, Sarah, Colby, these guys, C, are going to start out at JDC. Again, I'll put the address up there. JDC, your escort is going to be Professor Neese. She will meet you there, right probably at the entrance of the building, and she'll be with you until you leave. Coleman, your escort at Coleman, I have yet to have someone volunteer for that. So it actually could be an adjunct that you've never met before. I'm working on that, but we'll get you somebody down there that has a familiar face. Okay. The nursing lab, I will be in charge of that, running those simulations, and the Bora Center debriefing room, which is where our group D starts, Sarah and Celia and Shannon and Tracy and everybody in between. You're going to start off in the Bora debriefing room. This is where you're going to have an independent area to work on the schizophrenia case study. There's several questions. I'll have my DSM-5s in there for you because you have to do the CAP-RNs for the medications that are in the simulation. You're going to bring this with you when you come to the simulation, which your group D. So you eventually will get to the simulation by 10:15. Okay, just bring it with you. And then we'll rotate through. Group B, you'll be in the nursing lab, C's at Coleman, D's at JDC, and A's at the debriefing room. And it's that first debriefing room, which has the 2 rooms in it. We'll have the wall moved so you have adequate room and space, and you'll have the WIC walls where you can write on the walls. If you guys are all interested in working in a group, I'm fine with that. I'll put your instructions probably on the wall. to remind you where things are and what you need to be doing during this time. And you also have to keep track of the time because, like I said, everybody's rotating through. So the next group is going to be coming in to kick you out of that room and you'll have to move forward. So just keep track of the time there. And again, I'm going to adjust these times so that we start at 8 a.m. This 11:15 to 12, everybody is back in the nursing lab. We're going to be over by about 8 people, but that's okay. We're not going to spend a lot of time here. It may not take this whole 45 minutes. It's basically you doing an evaluation of the stations that you went to and turning in all of the work that you did, your case study primarily. Also, I do need to say, when you're in the nursing lab with me, there's going to be about 9 to 10 of you. 5 of you to 6 of you are going to be in simulation. And the other 5 during this time are going to be taking the schizophrenia quiz. So whenever you see that you're in the nursing lab, that's when the schizophrenia quiz is going to occur for you. Okay. So don't get excited. We're going to have the lecture. I'll have the lecture recorded for you, and then you'll be able to review it before you come in for HPS Day on November 25th. This is the objectives for it, and this is our simulation. Robin Martz has been around a long time, and she is a sick little girl. So, like I said, there's going to be 4 people presenting themselves as Robin Martz in 4 of the simulation rooms or in the checkoff rooms back in the lab. Your job is to complete the following assessment of the person. It's just a basic head to toe, and then you're going to be doing documentation of the head to toe as far as you can get. That part of the simulation is during the lab. These questions for before and after the simulation is what you're going to be working on in the debriefing rooms. So, okay. If you haven't had the simulation and you start with these, just do them as if you were supposed to, or you're thinking about what you would do and how you would interact with Robin. Okay. There we go. So in a nutshell, there it is. You can work ahead if you want to, but I'm giving you adequate time to do it while you're here. There's your groups. Take a look. I'm not changing anybody from any group. It's not going to happen. And we will be taking attendance at every time you come through for the group, at every station. Okay. If you don't have any questions, or if you do have questions, bring them for me. Okay. Bring them for me on Monday, and we'll go from there. Okay. All right. I guess that's it. I will upload this right now and we'll go from there. I hope you have a good night. See you later.